Hello, my name is Dr. Emmanuel, and I'm one of the geriatric medicine fellows here at SUNY Downstate. So I'm going to be talking today about COVID-19, starting with the diagnosis. So the objective for this slide will be to discuss the history and physical findings on presentation, list the various tests used in the diagnosis of COVID-19 infection in older adults, identify lab findings in COVID-19, identify radiologic findings of COVID-19. So we're going to continue with the history taking in COVID-19 in older adults. So this slide is on, based on older adults. So the history taking in COVID-19 in the older adults, you want to kind of get a sense of the recent travel and the risk factors. You want to also inquire if they have been in contact with any confirmed cases. You also want to contact if they are like professionals from a high-risk institution, like high-risk workers with transmission within 14 days prior to the symptoms. So everybody who gets into the clinic for routine check or in the emergency room should get tested for COVID-19. So we're going to continue with the clinical presentations of COVID-19. So the most common presentation that you'll find in COVID-19 will be the patients who present with fever or a cough or a shortness of breath, or they'll have altered sense of taste and smell. The less common symptoms will be like flu-like symptoms. They may also have upper and lower respiratory tract symptoms. So flu-like symptoms like myalgia and arthralgia, they may be fatigue, or upper respiratory and lower respiratory symptoms like cough or shortness of breath or nasal congestion. So some patients might be asymptomatic without any symptoms, or they might be symptomatic or some may present with very, very severe disease, like a pneumonia or acute respiratory syndrome, or like shock or a heart attack or a blood clot in their lungs or multi-organ failure. So we'll continue with the abnormal physical exam findings in COVID-19 patients. So like we said before, the patients might present with a fever or with a cough, shortness of breath with altered taste or smell. So listening to the lungs, auscultating the lungs of COVID-19 patients, you might get some crackles in the lungs, signifying that there is fluid in the lungs, or you might get bronchial breathing. Bronchial breathing is a high pitch breathing. It's like blowing through a hollow tube. So the patient might also have rising heart rate. They might be tachycardic. They might have increased respiratory rate, or they might have a bluish discoloration around their lips, signifying that they are lacking oxygen. Their pulse oximetry, which means their oxygen level in their blood might be low, probably like less than 90%. So continuing with the atypical presentation and co-infections, some patients may have atypical presentation, especially the elderly or the immunocompromised, and some also may have co-infection with bacteria. So in older adults and those who are immunocompromised, they might have very atypical presentation. They might present, the family member might say that they have been falling a lot lately, they have been getting confused, or they have been having like functional decline or reduced mobility. They might be also dizzy and passing out, or having like hiccups. And some elderly might also have absent fever. So in the older adults, some may not actually have symptoms, but you have to watch out because they can go downhill very fast. So 11.6% of COVID-19 patients might present with superimposed bacterial infection. And so we have to note that. And in hospitalized patients, 7% might actually have a bacterial co-infection. And those in the intensive care units, 14% of those in the intensive care unit with a positive COVID disease might also have a bacterial co-infection. So you have to keep this in mind. So when their COVID test is positive, we might also watch out for a superimposed bacterial infection. So the diagnostic, we're going to continue here with the diagnostic testings. So we have various tests to diagnose COVID-19. The most popular one is a molecular test. The molecular test is also called the PCR test. It's also called the viral RNA, and it's also called the nucleic acid test. So what this test, we get a sample from the nose, like a nasal swab. You get a nasal swab. You can also get a throat swab or a saliva or secretion from the lower respiratory tract. So this test looks for the viral genetic material. The results will take like from anywhere from 2 hours to a couple of days, maybe 2 days or so. And the false negative rate is more than 20%. If it's performed 5 days after symptom onset, but much higher, up to 100% if the test is performed earlier in the infection. So the false positive rate is close to 0. And if you have a false positive, it might probably be lab error. So the other test to diagnose COVID-19 is the antigen test. It's also a nasal swab. What this test does is that it looks for the viral protein fragment, the antigen, from the secretion. So the results, this one is the result is available in minutes, and it has, but it has a higher rate of false negatives than the molecular test, and it's also less expensive and very convenient and less complex to do than the molecular test. And so the false positive is also 0, and some experts might actually recommend repeat testing because the test is not so reliable. So this is just a picture showing how the nasal swab is done. The provider asks the provider will ask the patient to throw back the head, to take the head back, and expose the nose, and the swab is deep into the nose. It's kind of inconvenient, and patient might actually sneeze or cough. This is very inconvenient for the patient. So moving forward with the diagnostic testing, there's also the antibody test. The antibody test is a blood test. Unlike the molecular test and the antigen test, the molecular test and the antigen test, which were from respiratory tract secretions and they were nasal swabs, this is actually a blood test. So you have to give blood for this antibody testing. So this test for previous infection, the test identify antibodies that the body has produced in response to the infection, and the results are available in a few days. So having an antibody testing too early can lead to false negative. So it takes like 1 to 2 weeks after the infection for the immune system to build antibodies. So it takes like up to 2 weeks for the immune system to build antibodies. So that's the best time to get the antibody test. So if you take the antibody test very early in the infection, you might actually have a false negative. So false negative are like 20 to 30% for this antibody testing. So we're going to continue here with the laboratory investigations. So the most common laboratory abnormalities that most patients presenting with COVID, they might actually be asymptomatic, or the blood work might show that they have increased white blood cell counts, or they have increase in inflammatory markers such as the C-reactive protein or the excedrate. So other laboratory tests will be that they will be having like low platelets and elevated cardiac markers like troponin, and also abnormal liver function tests and renal function tests. So who should get tested? So those with symptoms definitely should get tested for COVID-19. Those without symptoms but have been in close contact with those who are infected, who are confirmed cases, and those who are also asymptomatic but the public health officials require them to get tested for COVID-19 should get tested. So we're moving forward with the diagnostic testing. So we're going to be looking at the imaging. So the chest X-ray is the most convenient and less expensive test, and that's a good place to start. And in case a patient has the disease, has positive COVID-19, 25% of COVID-19 patients will have just one lung, just a unilateral lung infiltrate, while 75% of COVID-19 patients will have bilateral lung infiltrates. So those lung infiltrates is actually the virus and fluid accumulation from inflammation, mostly seen there with those arrows at the lung bases. The CAT scan is the best test, but it's the most expensive test, and it's not usually done because the chest X-ray does a good job of picking up the disease. So the CAT scan is very sensitive. It's 90% sensitive in symptomatic adults, and the specificity can be anywhere from 25% to 83%. So this is just a flow chart that will help the providers to decide who get radiologic testing. So any suspected case of COVID-19 and needs clinical assessment and lab work done if you're suspected of COVID-19. If the patient is looking seriously ill, or if the lab test come back concerning for COVID-19, the patient needs a chest X-ray. And if it's positive, then the patient needs to get isolated and start treatment. If the patient looks stable, getting a chest X-ray will depend on the healthcare provider. So it's at the healthcare provider's discretion. But if the chest X-ray comes back negative, then the patient needs to go home and self-isolate.